Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 215 of the Better Health Guy blogcast series. Today's guest is Dr. John Neustadt, and the topic of the show is osteoporosis. Dr. John Neustadt is the founder and president of Nutritional Biochemistry Incorporated, or NBI. He earned his naturopathic medical degree from Bastyr University, where he was awarded the Founders Award for academic and clinical excellence. Dr. Neustadt has published more than 100 medical articles, written 4 health and wellness books, and is now a #1 Amazon best-selling author in the field of osteoporosis. His most recent book is Fracture-Proof Your Bones, a comprehensive guide to osteoporosis. Dr. Neustadt was also an editor of the textbook Laboratory Evaluations for Integrative and Functional Medicine, which was used across the United States to train and educate physicians on using functional medicine with their patients. And now my interview with Dr. John Neustadt. Over 20 years ago, I was diagnosed with osteopenia when going through my own chronic Lyme journey and mold journey. I've recently heard of people in their early 20s being diagnosed with osteoporosis. Bone health is critical for overall health and particularly for our survival. I'm excited today to have Dr. John Neustadt talk with us about his book, Fracture-Proof Your Bones, a comprehensive guide to osteoporosis and all things bone health. Thanks for being here, Dr. Neustadt.
Thank you.
There are more than 200 million people, including 53 million in the United States, with osteoporosis. Someone breaks a bone every 30 seconds. Osteoporosis is most commonly seen in postmenopausal women, and there are 300,000 people over 65 each year in America hospitalized for hip fractures, and the odds of them dying within 1 year is 36%. Osteoporosis leads to more disability than high blood pressure, breast cancer, rheumatoid arthritis, stomach cancer, pancreatic cancer, ovarian cancer, and Parkinson's disease combined. $17 billion are spent each year in the United States alone on treating more than 2 million resulting fractures. So let's break into this important topic and fracture the mysteries of bone health. Dr. Neustadt, wondering if we can start just talking about bones and what bones are made of. Is it just minerals like many people think, things like calcium, or do proteins, amino acids, and collagen even potentially play a role in bone health?
Bone is a complex tissue, and like all tissues in the body, it's made up of different things. The common understanding that it's just minerals and all you need is calcium and maybe other supportive minerals is not accurate. And it's done people a lot of harm by just focusing on that and having clinicians, frankly, just focus on minerals. A bone mineral density test only looks at the mineral part of the bone, but the protein, the extracellular matrix is indispensable for bone health. There are 180 to 200 different proteins in bone alone. Collagen being the major structural protein, but not the only one. And more than just, though, being a structural tissue, bones being strong so that we can stand and run and hug our loved ones and, do all the things we love to do. Bone also produces our red blood cells, our white blood cells, and our platelets. It is a dynamic organ that is continually renewing itself and through a process called bone remodeling, where about every 10 years we have all new bone. And in order to have healthy bone, you have to give the body all the raw materials that it needs to do its job that it wants to do, and also identify dangerous substances and activities that are keeping the bone from doing what it wants to do, or even worse, that are directly or indirectly destroying bone health.
So, extending on that, then, let's talk a little bit about the factors that increase our risk of bone loss as we age. Are there specific comorbidities that are also observed in those with osteoporosis? And building on that, how much of a role do genetics play when we're talking about bone health, or is it more the epigenetic influencers?
The risk factors for osteoporosis are divided into two general categories, which are called modifiable risk factors and non-modifiable risk factors. Non-modifiable risk factors, as it implies, you can't change. So that includes your age. The older somebody gets, the greater their risk for bone loss, osteoporosis, and fractures. Modifiable risk factors include diet, lifestyle, things that you can change. Then there's potentially modifiable risk factors. And I put into that all of those comorbidities, these other diseases that exist, and medications that we know damage bone and increase the risk for fractures. Anything that causes chronic inflammation, so chronic inflammatory states like irritable bowel disease, ulcerative colitis, Crohn's disease, autoimmune diseases, those are known to destroy bone and create increased fracture risk. Cancers, many cancers have an inflammatory component, also risks for fractures and osteoporosis. Beyond that, though, the medications used to treat many diseases, there's a long list of medications that damage bone. The most common ones, the most commonly prescribed medications, in fact, do that. About 25% of women 65 and older, which is the prime high risk demographic for osteoporosis, is taking an antidepressant. And the most common antidepressants are ones that increase serotonin. There are serotonin receptors on bone, and those medications like Prozac, Lexapro, they destroy bone. And they, so much so that now we know for every 19 women taking one of those medications for more than a year, we will expect one of them to break a bone. Other common medications, acid blocking medications like the proton pump inhibitor medications, damage bone and increase fracture risk, all the way up to increasing hip fracture risk, which is the most dangerous type of fracture, by 60% after taking them for several years. And this is not new information. The first FDA warning letter about the proton pump inhibitor category of medications went out in 2010. Glucocorticoids like prednisone, about 1% to 2% of the population are taking those medications, and chronically for autoimmune conditions, rheumatological conditions, GI conditions, and those are powerful bone destroyers. 30 to 50% of people taking a glucocorticoid will break a bone. One last one is aromatase inhibitors, those that are suppress estrogen production, that are used in breast cancer and other estrogen receptor sensitive types of conditions. We expect 20% of those women taking an aromatase inhibitor to fracture within 5 years. And the role of estrogen is really important, as I'm sure your listeners know. Postmenopausal osteoporosis is the most common type of osteoporosis, and that happens when estrogen drops around menopause. During menopause and for the 10 years after is when the fastest rate of bone loss occurs in women. And importantly, though, and this is really crucial because most clinical encounters, most of the time a perimenopausal or postmenopausal woman will go in to see their doctor. They'll just assume that, oh, you have menopause, and that's really the problem is estrogen. But in up to 30% of the cases of postmenopausal osteoporosis, something else also is going on. And so making sure that you're getting the right evaluation, making sure that more than just your estrogen is being taken into account is important.
So we're going to dig more deeply into a lot of those things that you just mentioned. I wanted to just kind of wrap that question up with, is there a genetic component in osteopenia, osteoporosis, or is this not a condition that has a significant genetic contribution?
That's a great question, and I get asked that a lot. There is no compelling evidence right now that the genetics of osteoporosis have been defined well enough that we can say this is the gene, or these are the series of genes that when there is a genetic abnormality, you are definitely going to get osteoporosis. Like all tissues, I mean, there are lots of genes being turned on and turned off all of the time. And even the CDC's position on genetics is that genetic abnormalities are very important when we're young, meaning that there's a higher risk for mental health issues, learning disabilities, death, decrease in growth. When you have these rare, already defined genetic abnormalities. But as we get older, it's more the environment and lifestyle, those epigenetics that you mentioned, that are much more important in terms of our long-term health. And that includes with bones.
What distinguishes osteopenia from osteoporosis? Is it simply that someone tested earlier and found the issue before it progressed from osteopenia to osteoporosis, or are there any differences in how those two conditions might be managed?
There are differences in how they're managed, and that is an ongoing debate of how to manage both effectively. And it's really, levels of severity of bone loss. So both indicate bone loss. Osteopenia being you've lost less bone than osteoporosis. They're defined by a test result on a bone density test, a dual X-ray absorptiometry test, or something that can give the equivalent of a T-score, like a certain CAT scan algorithms can do that. But a T-score of up to -1, so they're reported in the negative as a negative number because it's showing your bone lost. You've lost bone, and specifically a T-score compares your bone density to somebody of the same gender, so a woman in her 20s of the same race. And a T-score of -1 to -2.5 indicates osteopenia, and a T-score -2.5 or lower, -2.7, -2.8 is osteoporosis. Research has come out that has shown that, in fact, there's a higher risk of fracture when somebody has osteopenia than osteoporosis. And they're different. We can speculate as to why. It might be that people don't take it as seriously. They're not being as aggressive with treatment. It also could be that the cutoff values for defining osteoporosis are just need to be refined and moved a little bit. But regardless, once you start losing bone density, there is a risk for fractures, and I do think people need to do something about it. However, I caution people not to overemphasize the value of a bone mineral density test. A bone mineral density test only predicts 44% of women with osteoporosis who will fracture, and only 21% of men. And in fact, when you combine I was just reviewing a study just this morning, when you combine the bone density test with other predictive variables, like somebody's gait or mobility and a few other variables, when all of that is teased apart, because all these variables interact, a bone density test is only predictive of about 4 to 5% of people who will fracture.
So the T-score that you were just talking about, that's what people will probably commonly know as the DEXA testing. So at what age should someone consider doing a DEXA? Is that something everyone should do at a certain point in their life? And then building on that, and you've kind of alluded to this a bit, but if bone strength is bone density plus bone quality, how well does DEXA determine true bone strength or bone health? And can we get closer to that bone strength by looking at a trabecular bone score or TBS?
So first of all, with respect to I'm going to take this backwards a little bit because we're talking about the testing. With respect to the trabecular bone score, there is some added benefit to that, but it's only valuable for vertebral fractures. So it can enhance the predictive value for vertebral fractures in women. And there are some limitations to that, meaning it's not valuable for somebody less than 50 years old. And I think there are some subtleties in interpreting it. The challenge is that a lot of the times these tests are given too much emphasis and too much weight, and they're over interpreted. And that's what I see with the trabecular bone score. Hip fractures are the most dangerous type of fracture. Trabecular bone scores are not applicable to hip fracture risk. So that's the one caveat with that. Who should get tested with the DEXA test? I like the Bone Health and Osteoporosis Foundation recommendations. I'm on the corporate advisory roundtable for that association. And that is anybody 50 years or older who fractures a bone should get a bone density test, because osteoporosis and bone loss are asymptomatic. It's silent. It happens without symptoms usually. And a lot of times the first indication that you have a problem is that you break a bone. So I like that recommendation from them. Beyond that, generally, the recommendation is that women who are postmenopausal should get tested. Women who are premenopausal but with risk factors should get tested. And a lot of people fall into that category. So I'm a lot more generous with my recommendations of who should get tested, because we know many things increase people's risk. So anybody who's on one of those medications that I mentioned and others, there's a long list, I believe should have a baseline bone density test and then follow-up testing. Anyone with any comorbidity, any other disease that's known to damage bone and increase fracture risk should get a bone density test. And in fact, the testing is not being done, unfortunately, despite the limitations of the bone density test, even with people who are eligible by the most conservative recommendations. So with Medicare age population, that's 65 years or older, only about 5% of those who are eligible are getting tested. So this is something that people need to advocate for themselves. They're going to need to ask their doctors for it, because it oftentimes just does not get ordered. In terms of what you asked, the value of the bone density test for predicting bone fractures, it's limited, as I mentioned. It only predicts 44% of women with osteoporosis and 21% of men who will fracture. Every medical association that has looked at the data has correctly concluded that fracture risk depends largely on factors other than bone density. And I emphasize that with patients, because a lot of times they come to me and they're scared. It is a scary diagnosis. All that's been the focus of their conversation with their doctor usually is that test. And the only thing that's typically monitored is the number on the test. So I have them take a breath. I put to calm down a little bit. And then I put the testing in its proper perspective. And that is, I tell them what the true value is of it. It's limited. It is a small piece of a much larger puzzle. And then I walk them through, as I do in my book, how to put those pieces of the puzzle together to create a bone health program that makes sense for them.
So let's talk about some of the bone turnover markers that can be explored with blood or urine. So serum CTX or C-terminal telopeptide of type 1 collagen, or urinary NTX or N-telopeptide. How are those potentially helpful? What are they looking for to determine active bone breakdown? And then extending on that, let's talk about the P1NP, or the pro-collagen type 1 N-terminal propeptide, and how that might help us determine the rate of new bone formation. Are you finding these tests to be clinically useful?
I'm not. I don't use them. The longer I've been doing this, the fewer tests I'm ordering. Those markers for bone health are really problematic. And this falls into the category of clinicians ordering them and interpreting them for patients and not putting them in the lab testing in the proper context. And I'll give you some examples. So first of all, there are only 2 laboratory markers that are recommended by associations, the International Federation for Clinical Chemistry. I don't remember the exact name of it. And that is the CTX and the P1NP. And those are used, the recommendation is for monitoring response to treatment, not for predicting fractures. The challenge with those they're called bone turnover markers, is that they're very sensitive to a lot of different factors. So, for example, if you exercise within 72 hours prior to getting the blood drawn or your urine taken for one of these tests, it can be falsely elevated. If you're not fasting, it is falsely elevated, depending on the time of year. So bone remodeling or bone turnover is higher in the winter. And so those markers are going to be elevated in the winter months versus the summer months. So you have to make sure you're interpreting any change in the test values based on the season as well. Also, if a woman is still getting her period, the time of month in her cycle will also make those values fluctuate. And so the clinical interpretation and the clinical utility is very limited. I've had some patients come to me who have said that they've had some of this testing done and their doctor told them that, they are fast bone losers. They're losing, they use a ratio of these markers, like a ratio of CTX, which is a marker for collagen breakdown in bone, to the P1NP, which is a marker of building bone. And they'll say, you're a fast bone, you're breaking down fast now, but you're early in menopause, so that will slow down, or vice versa, meaning you're only slowly breaking bone down. The problem is the research shows is that's only accurate about 50% of the time. And so, which makes it clinically useless. And that's what I mean, that a lot of clinicians are ordering these tests and they're over interpreting them, and they're giving patients a false sense of either danger or a false sense of security.
Is there a place for REMS, or radio frequency echographic multispectrometry, in assessing bone health?
I think the technology is getting there. That's a relatively new technology. It's an ultrasound technology. So one of the benefits of ultrasound versus a bone density test, a DEXA scan or a CT scan, is that the ultrasound, whether it's a heel ultrasound or the REMS test, which is a new device that just came out in about 2018, that is also an ultrasound, is that the ultrasound does not expose somebody to radiation. And so that's a benefit. It can also be portable, so it can have better access at health fairs or pharmacies or even in doctors' offices. One of the challenges, though, with any of these technologies is that the gold standard is the bone density test. So every technology is compared to the bone density test in terms of fracture prediction. And overall, these ultrasounds, that category ultrasounds, CAT scans as well, have been shown to only be as helpful or as predictive as a bone density test, not better, until the REMS machine came out. There's one company that produces it. It's a technology that came out of Italy. And there have been two validation studies. A validation study then takes the technology and compares it to the gold standard, the DEXA test. The first study showed that it was the same. Predictive value was the same. No, not better than a bone density test. But then they came out what's called a fragility score, then takes a database of healthy bone scans and compares it to the patient's bone scan. It's done of the spine and of the hip. And then it gives a prediction of the risk for fractures. And that actually goes down all the way down to 20 years old in 10-year increments. The bone density test, the T-score, is only valid down to 50 years old and for postmenopausal women. And so the REMS test can be used in people who are younger than that, which is great. And when that fragility score is applied, it was better than a bone density test at predicting fractures. So I think it's promising that that is one validation study that showed that it's superior to a DEXA. I'd like to see another one, an additional validation studies just to confirm that. But I think the technology is exciting. I think it's promising. One of the challenges is it's also still not widely available and not covered by insurance.
So one of the potential advantages of REMS is that it can provide this fragility score, which might give us some indication of the potential for fracture. A lot of the other tests don't give us that fracture insight. In the book, you talk about the online FRAX tool, FRAX, and how that might be helpful in getting a little more information around fracture risk and predicting the risk of future significant fractures. So how does that FRAX tool fit into the clinical information collecting picture?
So just one clarification, you said the other tools besides REM, the other technologies don't give insights into that fracture risk. And that I just want to make sure people understand they do. They all can provide insight into somebody's fracture risk, but they're all very limited. And even the REMS test is limited. So there is some predictive value. If it is an ultrasound that's of the heel, though, people have to make sure that the technology is been validated. So I just want to mention that.
But what I was understanding was that DEXA by itself is giving us more insight into mineral density, but not necessarily a great tool for predicting fracture risk. Is that still true?
So it depends on how we define what is a great tool and what is not a great tool, what that cutoff is. So the bone density test and low bone mineral density is associated with fracture risk. And as I mentioned, a bone density test using a DEXA scan will predict 44% of women with osteoporosis who will fracture and 21% of men. So in my book, that's not a great test. It is the gold standard. It's the best we have with respect to what's conventionally available and accepted. And it is also one piece, again, of a much larger puzzle. I think it's also important to understand that if you get the testing done, for example, if you get a bone density test done and your bone density improves, we have an understanding of how that reduces your fracture risk. There are no outcomes studies yet looking at changes in REMS. If you were to improve your REMS score, does that also decrease fracture risk? We don't know. And those are important questions in terms of research that still need to be answered. Because with, for example, the surrogate marker testing we talked about before, CTX and NTX and P1NP under carboxylated osteocalcin, which you didn't mention, there are no outcome studies looking at just changing those markers. Does decreasing that actually reduce fracture risk in prospective controlled clinical trials? So that's where the limit of our knowledge is at the moment. And I think that it's just important to understand that we have the probabilities that all we can do is give somebody their risk for fractures and help them understand how they can modify and reduce those risks. And most of those modifications, most of that reduction is going to become in areas where they don't necessarily change the number on a test.
So is there any clinical value then in that FRAX tool that you talk about in the book?
There is. So FRAX has been validated. FRAX is a free online database. It's tailored to people in different countries. So when you go in, you've got to look for your country, make sure you're doing it based on your country. It's limited too. I mean, it does give you a 10-year risk score for fractures, but even that is limited because it only looks at a couple of different medications that you're taking, not a comprehensive list. It is not applicable to people who have had, for example, a stem cell replacement treatment. And I see FRAX, just like I see most of these other tests, as a way to raise awareness, to start conversations and have people be more motivated to make the holistic integrative changes that we know reduce fracture risk and improve bone health.
I want to talk about bone alkaline phosphatase. It's said to be produced by osteoblasts, which are those bone building cells, compared to osteoclasts, which are breaking down bone. So this alkaline phosphatase is said to serve as a potential indicator of the function of the osteoblast. So I'm wondering if bone-specific ALK-Phos is testable. Is that different from what we get on a standard blood test? And how might that guide our treatment or understanding? And if someone's alk phos is consistently low, is that something that should be addressed in the therapeutic intervention?
This is a great question. So alkaline phosphatase is produced by different cells in the body and different tissues in the body. So a bone-specific alkaline phosphatase is measuring, just as it implies, the specific alkaline phosphatase in bone. And that can give you some indication of the metabolic activity of bone cells, specifically those osteoblasts. It is associated with better bone health. It is associated with reduced osteoporosis risk. There are no outcome studies, again, looking at if that specific marker goes down, keeping all other variables constant, do we reduce fracture risk? And so that's where I think, again, testing for me is a way primarily to have conversations with people to help them get motivated to make the changes that, yes, can improve the alkaline phosphatase. If it's persistently low, I don't know of anything that will just target that to raise it. What we want to do is look at the overall metabolic health of what's going on in the cells and the microenvironment, and see what we can to just maximize that. Because all of these things, it's a complicated network of interactions. These different chemicals, the different markers, the cells, the extracellular space, even the mechanical load. When people jump up and down, about 95% of the cells in the bone are called osteocytes, which respond to gravity and forces and become metabolically active. So it's really about, for me, looking at the overall tissue and how can we increase or improve that microenvironment in the bone so the bone can do what it wants to do anyway.
So is the standard alk phos test that people get on a CBC or CMP, that's not bone specific alk phos, is it? Or can we derive some information from the alk phos that's on a standard blood test?
Well, I would say you could arrive some on it, but I would want to combine it with some other types of indicators. This is when I think about bone health, I guess the bottom line is it's a multivariable analysis. It never comes down for me to just one thing in terms of understanding bone strength and bone quality. When we're looking at a laboratory testing, so alkaline phosphatase is one indicator of risk, but I don't remember the exact number. I think it's, if you're looking at an alk phosphatase, I don't remember if it's 20 or 50% of that is not from bone, can be from other sources in the body. So if you want to dig deeper, then you'd order a specific bone alkaline phosphatase, but I frankly have never done that. On a standard CBC test, you can look at what's called the neutrophil to lymphocyte ratio, or a white blood cell test, a WBC test. Neutrophils are a type of white blood cell that respond to inflammation and infections. And we know chronic inflammation is a risk factor for osteoporosis and fractures. And if that neutrophil to lymphocyte ratio goes above as 3.17 or higher, that is associated with osteoporosis. Somebody could be losing bone. Then I also want to look at their vitamin D status. The maximum fracture reduction on a vitamin D test is 30 to 44 nanograms per milliliter, and that's hip fracture reduction. So I want to make sure that is at least within that range. And for immune health, a lot of clinicians, myself included, like it much higher, at least 50, 60, or 70, kind of are in that range. But a lot of people are below even 30. To tie that into the story of bone density and why bone density test is limited, is you see bone density increasing as when a serum vitamin D test as low as 9 on a test result, but you don't get that optimal fracture reduction until the number is 30. So you can have your bone density increasing, but fracture risk not decreasing. And that's why looking at different things, not just alkaline phosphatase, but some of these laboratory markers, definitely the lifestyle factors, the diet, and those sorts of things are important.
I have a cousin who is still younger than the 65 and older group, but had a fall just tripping on a blanket, shattered her knee. And so one of the preventative steps that you talk about in the book is to really fracture proof your home so that you don't have an avoidable fall. Wondering if you can just talk to us about some of the things we should be thinking about to fracture proof our homes.
This is an important and conversation to have, and one that unfortunately is not being had clinically often enough, because 95% of fractures happen because somebody falls. So anything that we can do to reduce the risk for falling is going to reduce the risk for fractures and other fall related injuries, concussions, bruising, lacerations, all of that. So there's some simple things that are common recommendations that people can find on the internet or in my book. And that is first of all, grab bars in the bathroom, handles if you're sitting, next to the toilet, in the shower, outside of the shower or the bathtub, to be able to steady yourself in case you lose your balance. There's something to grab onto. That's a lot of people know of that recommendation already. Ones, though, that people don't know that are also really important is to make sure the lighting in pathways that you may walk at night, like if you get up to go to the bathroom, are well lit. And people can get very inexpensive lights that are motion sensor that even just plug into a light socket along the floor, along the wall. If you get up to go to the bathroom, they automatically will turn on so you can see better. Also, make sure that those walkways that are commonly traversed are free of clutter. There's no coffee table with the corner sticking out, jutting out a little bit into the walkway where somebody could catch a leg or catch their thigh on and take a tumble. Making sure that any loose steps are fixed. Making sure that handrails on stairs are fixed and solid. And those are just some of the, I think, important recommendations that people need to take seriously.
I want to talk a little bit about why balance and muscle strength are so important when we talk about bone health and minimizing the potential for falls and fractures. What do you suggest to your patients in terms of exercise to help with balance and strength? Do we need more aerobic exercise? Do we need more resistance training? Do we need a combination of both? And then wondering, a listener had asked if you have any experience with the Onero program for supporting bones and muscles.
Oh, I haven't heard of that one. I will look it up. Thank you. I've not heard of Onero. In terms of muscle and balance, those are crucial. And it's non-negotiable, frankly. If somebody wants to reduce their fracture risk and improve their bone health, that's a non-negotiable for me of any program. But how somebody approaches that, I believe, can be tailored to what interests them and their specific limitations or capabilities. And one of the things I like to say is the best exercise is the one that somebody's going to be doing consistently. With bone health and osteoporosis, it's a chronic issue, and this is not something that happened typically overnight. It can take decades or longer for this to happen, and it takes time to reverse. And so there has to be consistent effort, day after day, week after week, month after month, to get the best results. But within that, those options, there are lots of options that people can do. I'll start with ways that people can just work exercise into their daily life, because that's one of the challenges, I think, for a lot of people, is carving time out to go to a gym, to go to a class. And both of those are great if that's what interests you and you have the time to do it, but they're not necessary. So what we find is that, anything that can, again, increase balance and strength is a good thing. Stork exercise I like to teach, and it's in my book. And that is, while you're brushing your teeth, just stand on one leg while you're doing the bottom teeth, switch to the other leg during the top teeth. That's, 1 minute for each leg, twice a day. That's going to increase some little core strength, some strength in your legs, and over time help improve your balance. Take stairs instead of the escalator or elevator. If you are at a shopping center, park further away from the front door so you're getting more steps in. The research shows that just getting on average 7,000 to 7,500 steps per day is associated with a 50 to 70% reduction in all-cause mortality. And that's from any cause, including fractures from osteoporosis. In terms of what other things people can do, if you've got a chair, you can do some chair dips. You can go to the floor and do some push-ups. If you like gardening, gardening's phenomenal for balance, and it's good for strength because people are squatting and they're leaning over and they're bending and stretching, to reach things and lifting things. So all of that is great. I think that with respect to going to a gym, if you do go to a gym and you have osteoporosis, or you are taking a class and you have osteoporosis, you've got to be very careful that you're doing it safely. There's only been one clinical trial that's been published on people with osteoporosis and with fracture outcomes in exercise. And what they found is that when you're doing flexion exercises like sit-ups, that actually increased their risk for fractures. They had a greater fracture risk than people who are doing extension type movements. So be aware of that. And it's important, if you're going to be working in the gym and you have osteoporosis or go to a class, that you vet the trainer, that you work. I recommend people work with a trainer if they have osteoporosis, and they make sure they're a specialist and they understand what to do. There are online classes people can take as well that experts in this field and exercise have created. So I don't think there's definitely not a one size fits all. What I will caution, though, against is that you cannot exercise away a bad diet. And so diet and exercise, to me, are two sides of the same coin. You cannot have one without the other. And I'll give you an example. One of the important things is maintaining or increasing muscle strength, muscle mass. As we get older, we tend to lose, just like we tend to lose bone density, we tend to lose muscle mass and muscle strength. And what we know now, based on the research, is one of those reasons is people aren't consuming enough protein along with doing the proper exercise to build strength. As we get older, the amount of protein that we need increases. And there's a clinical trial that came out that showed that when people eat adequate amount of protein, all the way up to 85 years old, and do resistance training, they build muscle. Another study, though, showed that even just a few weeks of only eating the USRDA for protein, and people lost muscle. So you've got to get more than the USRDA. I like to recommend, if people take their body weight in pounds and multiply it by 0.6, that'll give you the number of grams of protein minimum that you should be eating a day, as long as you don't have a chronic kidney disease and you're on a protein limited diet. And that will give that raw material necessary for you to build muscle. And then you've got to create the environment for that muscle to be built. And that environment is resistance type of exercise.
Let's talk a bit about calcium. We know it's a key part of bones, but it really can be a double-edged sword in that we want to be sure that supplemental calcium gets into the bone and not into our vasculature. Many people ultimately die from calcification. So I've always been a little hesitant about supplemental calcium, but maybe that's misguided. So what's the best way to test for either calcium deficiency or calcium excess? And if we then need to supplement calcium, how do we minimize the potential for creating other significant problems by really wanting to focus on driving that calcium into the bones rather than into our vasculature?
Great questions. So first, I'll say with the calcium question is most people should be getting it from diet, not dietary supplements, ideally. Diet is always first. And I believe supplements should be used as the FDA intended. That is, as a supplement to a healthy diet, or when clinical trials show specific nutrients can benefit people with specific conditions in those doses. With respect to calcium, there is some controversy now around the safety of calcium. And I do think that most people are getting way too much calcium. The average American woman consumes about 800 milligrams of calcium in her diet, and the average American man, 1,000 milligrams. The USRDA for calcium for women is 1,200 milligrams per day, and for men, it's 1,000 milligrams per day. There's no evidence that getting higher amounts of calcium than that improves bone health. So the average American woman, and hopefully people are eating better than average, probably shouldn't get more than about 400 milligrams of calcium in a dietary supplement. And men typically won't need calcium as a dietary supplement. The current recommendations from the Bone Health and Osteoporosis Foundation and the American College for Preventive preventive cardiology is that people should not consume more than 2,000 to 2,500 milligrams of calcium per day. And that's from all sources, diet plus dietary supplements, because then you start running into potential cardiovascular problems. The question of how to test calcium is a challenging one to answer because there isn't a good test for calcium. Calcium accumulates in the blood, and it's tightly controlled because it's involved in kind of creating electrical transmission across cell membranes, and so having it well controlled in the blood and making sure the blood calcium is within a narrow range is an advantage to our survival. So the gold standard for nutritional testing when you're looking at minerals is what's called an intracellular test, or our red blood cell test, where they isolate the cells and they look at the amount of minerals in those cells, magnesium, copper, zinc. They accumulate within the cells. And so we're able to get a good understanding of what somebody's nutritional level is. But calcium is different because you have a giant reservoir of calcium in your bone. And when you don't have enough calcium, it's going to start pulling it from your bones, and it's going to increase the calcium then into your blood to keep it within a very narrow range. So there is not a good test of whether or not somebody has enough calcium. The best way, I think, to understand that is for somebody to track their diet for a couple of days, write down what they're eating, you take a diet diary, and then calculate about how much calcium are they getting in their diet. That's probably, I think, the best way to do it. In terms of looking at calcium directing it to the bone, this is an area that I find supplement companies will make claims about. We have a nutrient that will direct calcium out of the arteries into the bones. Well, there are no clinical trials showing that, none. It's all based on theoretical mechanisms that may or may not be accurate. Because the calcium is going to be maintained in a very tight level in the blood, and extra calcium is typically going to be excreted in the urine. Now, if calcium is being deposited in the arteries, the way and the mechanism by which atherosclerosis or hardening of the arteries occurs is the initial insult. The initial problem is not having calcium. The initial problem is inflammation. Is that there's inflammation that then damages the lining of the artery, that then activates the immune system, and these cells then migrate there to repair that tissue, and then they harden. And that hardening is that process of the calcification that occurs, kind of like putting a patch over a hole in a dam, or a hole on a hose. And so, just saying that we've got a nutrient then that directs the arteries, the calcium, out of the arteries. Well, there has been research looking at specific forms of vitamin K2 and whether it pulls calcium out of the arteries, and the research shows that it doesn't. And what the research shows, however, it may be beneficial. There are contradictory studies on it, that it may slow down how fast atherosclerosis progresses if somebody already has it. But there is no indication that it decalcifies calcium deposits once they're already in the arteries.
So we're going to talk a little more about your supplements that you've created, but I have to think your marketing department may not like your comments so much that we should be getting it from diet. But I have to say that says to me a lot about your integrity and the importance of the work that you're doing. You are a naturopathic doctor. Some practitioners use HTMA or hair tissue mineral analysis, look for things like a calcium shell as a potential indicator of calcium dysregulation or buildup or mineral imbalance. Any value that you found in HTMA testing in looking at people's bone health?
No. This is going to be a short answer. No.
How often do we see parathyroid issues as a contributor to calcium being lost from the bones, increasing bone turnover, ultimately leading to osteoporosis? How often is excess parathyroid hormone or PTH caused by a tumor that might lead to a surgical intervention? And what are some of the triggers that might lead to an excess amount of parathyroid hormone? How do we test for that? How do we look at this potential contributor to bone health?
That's a great question. I think that PTH is not elevated parathyroid hormone, or PTH chronically elevated, is not as common of an issue as the other risk, some of the other risk factors that I already mentioned, like not exercising, sedentary lifestyle, poor diet. I think those are bigger risk factors. In terms of PTH, there is what's called primary hyperparathyroidism and secondary hyperparathyroidism. That is, primary means it's elevated and we're not really sure the cause. We can't identify the cause. It's just elevated by itself. Secondary means there's another underlying cause that's creating this issue. Most commonly, what I see is people don't have enough vitamin D. So PTH, when it's elevated, frees calcium from the bone. It releases calcium from the bone to, again, regulate calcium in the blood, to make sure that calcium in the blood is within a certain healthy level. So when vitamin D is low, that can cause parathyroid hormone to increase, because one of the roles of vitamin D is to increase calcium in the blood by enhancing calcium absorption in the intestines, and then not letting calcium escape the body in the kidneys and in the urine. It increases what's called the reabsorption. Once calcium starts heading down the little microtubules in the kidneys, vitamin D helps to that calcium to get reabsorbed so you don't lose it. So it helps to retain the calcium as well. So when vitamin D is low, parathyroid hormone can be elevated. Too often, I've seen an elevated parathyroid hormone on a lab test ordered by other doctors, and they also have not tested vitamin D. And that's a mistake. Vitamin D should always be tested when parathyroid hormone is tested, in my opinion. Other causes, you could have a tumor, for sure. You could have some sort of cancer happening. And those are, more secondary causes of elevated parathyroid. If you have a parathyroid cancer in the parathyroid, where parathyroid hormone is produced, which is these small, tiny little glands on top of the thyroid gland. So the thyroid gland is here in the bottom of the neck, and it's a butterfly-shaped gland. And then you have 4 discrete little areas within that gland that produce parathyroid hormone. And if there's tumors there, then that could also increase parathyroid.
In the book, you say that 83% of people 60 and older are on pharmaceutical medications. 91% in care facilities are on 5 or more pharmaceutical medications. So I want to talk a little bit more about that. You touched on this earlier. And in the book, you talk about a lot of these medications that are very common: PPIs, antacids, antidepressants, some antihistamines, benzodiazepines, blood pressure medications, diabetes medications, maybe too much thyroid hormone, the steroids or glucocorticoids, which are also contributors to cataract formation, as I understand, muscle relaxants, opioids, and sleep medications. So how much of osteoporosis is really driven by these pharmaceutical medications? Are they a significant contributor to the development of issues with bone health? And how much is a direct effect of the medication on the bones versus maybe a side effect of the medication that increases the potential for a fall?
Great questions. And there's a lot to unpack here. So let me start by just saying all the medications that you mentioned and that are in my book, not all of them decrease bone density or damage bone collagen. There are different mechanisms by which these medications increase fracture risk. First of all, polypharmacy, and there's no official definition of polypharmacy, meaning are you taking 2, 3, 5 medications? There's no official uniform definition. What we know is when the more medications somebody takes, that is a risk factors for osteoporosis, falls, and fractures. The antihypertensive medications for blood pressure, those don't impact bone density. What they do is they can increase somebody's risk for falling. As we get older, what happens is our kidney, our liver that metabolizes the majority of medications can slow down in how well it breaks down and eliminates medications from your body. And when that happens, you can get a buildup of medication in your body. So if you were taking a medication at a dose, 5 years ago or 10 years ago, and you're still on that same medication, well, the dose of medication that was appropriate for you when you were younger may be too high of a dose now that you're older. And that's what we see with these blood pressure medications, is that doctors are not doing medication reviews with their patients to make sure that they're on the proper dose as they get older. And when blood pressure drops too low, people get dizzy, they lose their balance, and they can fall. Similarly with the sleep medications like the benzodiazepines, or what are called benzo-like medications. Lunesta is one of those, alprazolam, diazepam, any of those. Those also increase the risk for falling. They're used often for sleep, and people are already groggy when they wake up in the middle of the night to go to the bathroom and tend to have poor balance. Then you add a medication on top of that, one of those sleep medications, and their balance is even worse. And then if you have a blood pressure medication that's too high of a dose, your balance is even worse. And so all of those factors conspire against patients as they get older, and they need to be vigilant and aware of that. And talk to their doctors and get medication reviews. I actually talk in my book, and I'm a huge fan of people getting to know their local pharmacist. Pharmacists are incredibly well educated. Most of the time they stand behind the counter and they're just filling prescriptions all day. And yet they are the experts, even more than your physician, in medications. Talk to your pharmacist, get a medication review, ask questions of your pharmacist, and then you can take those back to your doctor and ask your doctor too, but don't just rely on your doctor. Get to know your pharmacist. They're incredible people, very knowledgeable, and they have quick access to all the latest databases. Then you have drugs that directly and indirectly damage bone itself, damage the tissue. So glucocorticoids like prednisone is one of those. And prednisone actually works. It does several things. One of the things that it does is it damages bone collagen. It decreases your ability to create bone collagen. It's that collagen that gives bone its ultimate strength and flexibility when collagen is healthy. Collagen, strand for strand, is stronger than steel. And what happens is that glucocorticoids damage collagen. They make it more brittle. And then they also reduce the body's ability to produce more collagen. And the minerals bind to those proteins. And so as you're losing collagen, or as you're losing maybe other proteins, you're also then starting to lose minerals. So the risk for fractures with prednisone increases before you even see a change in a bone density test. Again, another limit of the bone density test. But it also destroys fibers in the muscles. And so you also start to get worse balance and then increase your risk for falls. The SSRI medications, anything that increases serotonin, those directly and indirectly increase fracture risk. They directly decrease bone density because what they do is they increase the activity and how long these cells live of a type of cell called osteoclasts. You mentioned osteoblasts, those build up new healthy bone. Osteoclasts is the other major type of metabolically active cell in bone, and those break old bone down. They take old worn out bone and break it down. And when osteoblasts and osteoclasts are in balance, you don't have more bone being formed and you don't have bone being lost. So these increase the activity and how long those osteoclasts break down bone. And so it results in you starting to lose bone quite quickly. And in addition to that, because it affects the central nervous system, serotonin does, and it builds up serotonin, you also get what's called a decrease in sympathetic tone. And that then can increase the risk for falls. So we can go through a lot of the medications. They work by, under different mechanisms, but they all have the same result of increasing people's risks for fractures.
So I want to dig into a few of them in a little more detail. So let's talk more about the glucocorticoids or steroid medications. Is this high dose steroids? What about lower dose physiologic replacement with hydrocortisone in people that maybe have low cortisol? And then building on that, Cortisol is a steroid hormone that's produced in the body by the adrenals. So, how does stress and high cortisol from stress destroy our bones? And then, what do we see in people that have conditions like maybe Cushing's disease, where there are higher levels of cortisol in terms of their bone health?
Great question. A study was done years ago that looked at quote unquote healthy people, and it looked at their blood level or serum level of cortisol on a blood test. And it looked at whether they were low, all within the normal range. So where in the normal range were they? Were they towards the low end of normal, right in the middle, towards the high end of normal? And what they discovered is that the people who were still in the normal range of cortisol, which is secreted when people are stressed, as you know, especially with chronic stress, people that were in the high normal range of serum cortisol had faster calcium excretion. They were losing more calcium in the urine than other people. And we know that chronically elevated cortisol is a risk factor for bone loss, osteoporosis, and fractures. We see in Cushing's disease, as you mentioned, similar to just like if you were to be taking a prednisone medication, one of those medications. Even the dose packs, the shorter term, like a week or 14 days of people will do what's called a Medrol dose pack, where they dose somebody high for a few days and then they taper down in a shorter period to give somebody exposure, not over weeks and over months, but over a short period of time to deal with maybe an acute flare-up of inflammation. Even that has been shown to reduce bone loss. Even the glucocorticoid nasal sprays have been shown to increase the risk for osteoporosis. So maintaining it really, that stress level, the cortisol level in a more balanced, healthier range is to our benefit and for many different reasons, not just for bone health.
And do you have similar concerns about low dose physiologic replacement with things like Cortef in people that have a chronic illness? Should we be concerned about that?
So people who are low, I take the stance of similar if they have low testosterone or low estrogen or low progesterone. If we're getting them just back into sort of that mid range of normal, I don't have a problem with that. Now, there are no studies looking at that approach in osteoporosis and bone loss, but all the evidence points to that if it's within that normal range, not even high normal, but just that mid range, healthy range, then there don't appear to be risks.
Let's touch on acid reflux. It seems that most people have the idea that we need to lower acid, when my understanding is very commonly that is a sign of low stomach acid. And rather than maybe using a PPI, maybe hydrochloric acid could actually be helpful, or looking at food intolerances, or maybe even some fungal issues like candida, for example. What are some of the things that you would suggest people that have acid reflux explore before considering something like a PPI?
I love this question and I love your approach, because you're right. There are many different explanations of why somebody has acid reflux beyond just that they have excessive stomach acid, too much stomach acid. In fact, the opposite might be true. As we get older, people are at a higher risk for low stomach acid. And that could be due to atrophy of the stomach. It could be due to medications they're taking, like an acid blocker. Autoimmune diseases increase the risk for low stomach acid. And what happens is there's a muscle at the bottom of the esophagus, that tube that connects your mouth to your stomach, called the lower esophageal sphincter. And it separates the contents of the stomach from your throat. In acid, the pH of the stomach is a signal for that little muscle. It's a round muscle to close, to keep the contents separate. And so if you're not producing enough stomach acid, it keeps that muscle open, so that the acid that you do have in the contents of the stomach could just flow up and down. And so the problem might be actually that you don't have enough stomach acid, and there's testing that can be done. You can do a gastric pH test to see if you're not producing enough. And then you can also, if you don't want to do that, you can do a low dose hydrochloric acid protocol under the supervision of a healthcare provider, because you don't want to get too much stomach acid or it could burn the lining of the stomach. And there are reasons why some people shouldn't do that approach. You just want to make sure it's being done safely. And if your acid reflux gets better, that can be an indication of needing some more stomach acid. But then the question is, well, why? Why are you having too low of stomach acid? What might be going on? Infections can cause low stomach acid. An H. pylori infection, small intestinal bacterial overgrowth, medications, as we mentioned, all can decrease stomach acid. Foods can create problems beyond just stomach acid. Foods that then just create acid reflux. There are 5 most common foods that do that: coffee, chocolate, citrus, tomatoes, raw garlic, raw onions, spicy foods. People, though, need to experiment because the trigger might be individual, to you. It could be mint, for example, that does it to you. So understanding that and avoiding those triggers. About 50% of the acid blocking medications are prescribed just for one condition, and that is the acid reflux. And what we know, unfortunately, is when somebody then takes an acid medication, an antacid medication like a proton pump inhibitor, and then they start to get bone loss, what doctors have been doing is just saying, well, we use a bisphosphonate like Fosamax for postmenopausal osteoporosis, so we're just going to do it in this case as well. But the mechanisms of action are very different. How a proton pump inhibitor damages bone is very different than how a drop in estrogen with menopause damages bone. And what they finally found out when they decided to look at this and study it in clinical trials is that when somebody took a PPI plus Fosamax or an oral bisphosphonate, their risk for fractures was higher, was actually increased compared to people who only took the bisphosphonate medication. And so caution needs to be really, caution is the word of the day, I think, when trying to apply research from one medication clinical trial to all these different situations. But in direct answer to your question about, acid reflux and different ways that people can evaluate it and fix it, trying to identify the underlying cause first and foremost, I think is an important step.
Antidepressants like SSRIs can lead to a 68% increase in fracture risk, and 1 in 19 will break a bone in 5 years. You can see I actually read your book. Serotonin decreases the beneficial impact of osteoblasts and increases the harmful impacts, that breaking down of the osteoclast, as you mentioned. Is there a place for doing neurotransmitter testing to see if someone has high serotonin? Is that something we wouldn't commonly see unless there was some medication that was driving it higher? How do we explore and mitigate the potential for higher levels of serotonin on bone health?
So if you're talking about mitigating it with respect to the medication, if somebody's on the medication and should we test to see if they have too high, it's going to be too high. I mean, if somebody's on an SSRI, what they showed is even low dose SSRI increases bone loss. So the dose doesn't seem to matter. What seems to matter is that somebody's taking a medication that artificially elevates serotonin. Now, most serotonin is not in the brain. It's outside the body. Like 90% approximately of serotonin is produced in your intestines. It's not even produced in your brain. And there are about 15, I think 12 or 15 different subtypes of serotonin receptors. So one molecule like serotonin or melatonin does different things throughout the body depending on the receptor subtype. And in bone, that receptor subtype increases the osteoclast activity and increases the breakdown of bone. And so when you artificially elevate the serotonin, you get higher concentrations of serotonin in the bone. You're also getting a faster rate of bone breakdown. There is no test, that I think is really necessary to know if that's happening. We know from the research that it's happening. I think people should just save their money because it is happening. I think, though, that what we can do in terms of how to mitigate it, first of all, is can we decrease the dose? Can we get them off of that type of medication, either switching to a safer antidepressant if they need it, or frankly, the research is very clear, antidepressants aren't all that helpful anyway. So can you approach the mood disorder and the depression from a more integrative, holistic, naturopathic, functional medicine, whatever you want to call it, way to improve the mood so you don't need that medication to begin with? I think that's the best approach. In terms of mitigating the damage, anything that we can do to reduce what we're doing to the body to create harm, reducing that harm is going to go a long way to helping your body heal.
Would you have any concern about any supplements like 5-HTP, for example, increasing serotonin enough that it would have a detrimental impact on bone?
So I typically prefer tryptophan to 5-HTP because of the ability of what's called the rate limiting step. The body will regulate how much tryptophan is converted into 5-HTP. I haven't seen any research on 5-HTP and the bone health effects. I can't really comment on that specific supplement, but it is downstream. Once it gets to 5-HTP, there's nothing regulating or stopping it from continuing down its pathway that I'm aware of to go to serotonin. So, but I don't know of any research showing 5-HTP and at what dose is it safe, at what dose is not safe. I don't know.
You mentioned earlier that hormones play a significant role in bone loss. Part of the reason why we see this more in menopausal and perimenopausal women. Aromatase inhibitors, androgen blockers can increase the potential for osteoporosis. Wondering if you can talk to us a bit about the role of estrogen, progesterone, and testosterone on bone health. And if someone has a condition like PCOS or endometriosis, or maybe a breast or prostate cancer where hormones may be contributing to their condition, are there healthier ways of reducing those problematic hormones? Or do both natural and pharmaceutical options that are lowering some of those hormones have the same potential to negatively impact bone health?
But one of the challenges with the research is that there's not a lot of research on the effects of natural products on bone when it comes to looking at modulating these hormones. In fact, I don't know of any. So if we were to take a natural product to reduce estrogen, for example, that there's really no research then that has extended that to bone density or fractures. So the question is, we don't know. But when you get to the aromatase inhibitors, that almost completely block estrogen production. I mean, you're totally cutting it off. That's a very different story. I don't know of any natural products that completely cease the production of estrogen. So I've got to imagine that the effect on bone, if any, would be much milder than the medications. Testosterone, progesterone, estrogen, all contribute to bone health. Testosterone in younger years is what is contributes to the lengthening of bone to make them bones thicker and longer, which is why men tend to have longer bones, tend to be taller, and tend to have thicker bones than women. Estrogen then, when peak bone mass is attained in our 20s, tends to then maintain that bone mass, maintain that health. So testosterone is converted into estrogen in both women and in men. And so having some of that, testosterone in men and low testosterone is a big contributor to osteoporosis in men. Only about 20% of osteoporosis cases are in men, but testosterone, especially as we age, is a big contributor. But one thing that's not tested enough when a man gets his testosterone tested is also looking at the estradiol to get that estradiol, that specific fraction of estrogen called estradiol tested as well, because that's what testosterone is converted into, and make sure those are both in the healthy ranges. Progesterone also helps to maintain bone health. And when you look at perimenopausal women who are put on estrogen hormone replacement therapy, estrogen alone or estrogen plus progesterone, there's about a 28% reduction in fracture risk with that. The data stops up to age 60, and it seems to support right now that you're looking at, starting it while you're going through menopause. I personally don't, I believe it probably helps even if you start taking it later. I don't know why it wouldn't, but we just don't have the published data on that. But we do know that starting hormone replacement therapy, which can be done very safely, builds bone, maintains bone, but more importantly, it does reduce fractures.
One of the things that I've seen as women hit perimenopause, menopause, and they start having that hormonal decline and some bone loss that's accelerating is that they also can then release heavy metals that were stored into the bone, lead particularly, that then becomes in circulation, can essentially lead to an auto intoxication from the lead that was in the bones now being released into circulation. How important is considering heavy metals as a factor on overall health, and particularly when someone is experiencing bone loss?
I think it's a piece of the puzzle for sure. Understanding environmental risk factors is part of it. And there are certain areas of the country and certain exposures, occupational exposures, that make it more likely that people will have higher amounts of lead in their body than others. So being aware of that, I think, is important and is one piece of the puzzle for sure.
One of the things that you talk about in the book is heparin, and many in the world, especially in the pandemic era, are dealing with hypercoagulation, with buildup of fibrin, with clots and microclots. Medications like Lovenox are said to have a negative impact on bones if they're used longer than 3 months, as I understand. So which anticoagulants do you have more concerns about from a bone health perspective? Which ones might be acceptable for longer term use? And then building on that, where do you stand on warfarin or Coumadin and bone health? How do we manage the almost necessity these days of having optimal coagulation with the risks of negatively impacting our bone health?
Those are great questions. Coagulation is a very complicated process. There are two sides to this blood clotting, what's called the clotting cascade. There's the side where you're actually forming the blood clots, and that's where you get fibrin that you mentioned build up. And then there are the part where you are breaking the clots down. And we have to have healthy blood clotting. When we get unhealthy blood clotting, get too much, you can get thicker blood, or it increases blood viscosity. That is a risk factor for strokes and heart attacks, and it can also contribute to high blood pressure. I personally like to start looking at blood clotting and blood viscosity using natural approaches, because they are safer and they entail things that have no risk factors. And one of those is diet, making sure somebody is on a good, healthy, kind of blood supporting diet with antioxidants and lots of fruits and vegetables. That's helpful. Making sure people are well hydrated. That's helpful. Making sure that they're moving and exercising. That's helpful. If somebody has elevated fibrinogen, I like to use a product I created for my patients called Natopine. It's the highest dose nattokinase product on the market with pine bark extract. We guarantee that it will lower fibrinogen or maintain it in the healthy range. And that is elevated fibrinogen is associated with increased blood clotting risk. Garlic also been shown to decrease blood viscosity. High dose fish oil also seen to decrease blood viscosity. So there are different ways that this could be approached. If somebody does have to be on a medication, I don't like warfarin because it acts by blocking the formation of blood clots, by blocking vitamin K, the ability of the clotting cascade to use vitamin K. And what we know is the best dietary supplement nutrient for bone health, for improving bone density, and for maintaining strong bones, as indicated by reducing fractures, is a form of vitamin K2 called MK4 in the dose of 45 milligrams per day. That is the only form and the only dose of vitamin K2 that has been shown to improve bone density and maintain bone strength, meaning reduce fractures. There's another form out there called MK7. MK7 has never been shown to improve bone density, only slow down how fast somebody loses bone. And in some studies, actually, the women lost bone faster. And there are no outcome studies looking at fractures at all. Whereas MK4, 45 milligrams per day, has been the subject of over 45 or 25 clinical trials, multiple meta-analyses showing repeatedly that bone density improves. Even people on medications, people taking prednisone, people on dialysis, people on a Leuprolide or Lupron, which is an androgen deprivation therapy, stopping the bone loss or reversing it. And in postmenopausal women with bone loss, improving the bone density, but more importantly, reducing fractures by over 70%.
Want to talk about how sleep directly impacts bone health. What happens when we get poor sleep in terms of our bones, our risk for osteoporosis? We talked about sleep medications and how those could have an effect on bones, could lead to an increase in falls. But is there a direct connection between poor sleep and bone health?
People who get on average less than 6 hours of sleep a night have a faster rate of bone loss and increased osteoporosis risk than people who sleep more than that. Now that's the duration of sleep. And so you also want to make sure you're getting high quality sleep. If you're a very light sleeper, that could create its own challenges for being tired and not feeling refreshed in the morning. And when you're exhausted, you increase your risk for accidents and increase your risk for falls. So not only if you have chronic insomnia and not sleeping enough, are you probably getting faster rate of bone loss, but you're also increasing your risk for falls and other accidents. And in fact, research shows that insomnia or sleep deprivation is as dangerous as drunk driving when it comes to operating machinery.
Let's talk a little bit about the role of nutrient deficiencies on bone health. Wondering if you find any value in doing something like a NutriVal or a Vibrant micronutrient deficiency test to look for calcium, magnesium, B12, maybe iron, maybe, and then building on that, if we think about B12 and other methylation support, what's the role of high homocysteine on bone health?
Well, let me start with the homocysteine first. This is one of those instances where you can run a laboratory test, but there's no indication that lowering that number on the test makes any difference whatsoever when it comes to bone density or fractures. I have matured in my thinking with homocysteine so that now I think of it more as a marker of a poor diet. Homocysteine is lowered with B6 and folic acid and betaine, and those are found in foods. Now, if somebody has methylation defect, I think that is an important consideration. And you can I don't do much genetic testing, but that's one that can be done, in which case they just need to be supplemented with those methylated forms of those nutrients. When it comes just to bone health and testing, again, I tend to not test as much as I used to. If they have other symptoms going on that may indicate some of these deficiencies, like if they're getting muscle cramping, which could indicate a magnesium deficiency, if they have some mood dysregulation, if they have some depression or just decreased mood in general, and that could indicate some B vitamin deficiencies or amino acid deficiencies, and then I might consider some testing. But when it comes to my recommendations for bone health and osteoporosis, I go back to the question of what has been shown to not just improve bone density, but reduce fractures. Now, we do know that magnesium, serum magnesium and intracellular magnesium are associated with bone loss. But when you look at epidemiological data and you look at dietary magnesium is not associated with reduction in fractures. And there are no clinical trials showing that just taking a supplement with magnesium reduces fracture risk. I'm a big fan of magnesium. It's used for 250 different processes in the body. And I think that there are reasons to get magnesium, but the clinical trials on the MK4, and it's MK4 with vitamin D or calcium. By the way, I know all of this because I could not find the clinical trial dose used in products on the market almost 20 years ago now. So I created these bone support products with the clinical trial dose of MK4 to help people with vitamin D. Now, one without calcium, but a couple other versions with different amounts of calcium. And what we know is that the clinical trials that showed over 70% reduction in fractures did not use magnesium. So again, I'm a fan of getting it from diet. Let's really try and improve the diet, that foundation of health. And if it's just osteoporosis, again, I'm doing very little testing.
So that's a great segue to the next question, which is to talk about the optimal bone health diet. What should we be eating and drinking? What should we be avoiding? What's bone supporting versus bone destroying? Does milk provide us with calcium, or does it ultimately deplete our calcium? What about coffee, maybe acidic beverages? And then coming back to our earlier conversation about the role of protein in bone health, does it matter whether that protein source was animal-based, plant-based? If plant-based is important, what are your thoughts on the carnivore diet in terms of bone health? What is your osteoporosis diet?
You ask phenomenal questions. I'm loving this conversation. So I always go back to the question, what does the research show in terms of reducing fractures? That's the ultimate question. And what we know is that Mediterranean style dietary pattern has been shown repeatedly to reduce not just the risk for osteoporosis, but reduce hip fracture risk, the most dangerous type of fractures, by 21%. The more somebody adheres to that way of eating, and it's not a diet like a weight loss style, it is a pattern of eating to promote your health for the rest of your life. It's essentially a plant-forward diet with adequate amounts of fruits and vegetables and whole grains and protein. And it's basically the opposite of the standard American diet. The Mediterranean style diet is low in processed foods, low in trans fats and fried foods. And it's just a nice whole foods, plant forward diet. Teaching people how to eat that way can be challenging because it's not intuitive. Most people are not eating that way to begin with. In fact, ultra processed foods now make up about 60 to 70%, 60% of the calories in the US diet. So moving away from that and towards a whole foods diet is a transition that's challenging for people to eat. So in helping people move into eating that way, I just have them focus on two things, plants and protein. I recommend people get 30 grams of dietary fiber per day from all sources. And they calculate the amount of protein they need based on their body weight. So take your body weight again in pounds and multiply it by 0.6. And that's the minimum amount of protein to be getting. And I have people transition into eating that way over 4 to 6 weeks because major changes done overnight tend not to be sustainable. And this is really developing new habits and understanding of how to eat to promote your health for the rest of your life. Absolutely, dairy, milk, it has calcium. It's also not necessary. And it has some other things that concern me beyond just the calcium. The calcium in dairy, first of all, can go towards that total RDA amount, but there are other sources found in almonds and vegetables and sardines, if you eat sardines, that have lots of calcium in it. There's a blog on my website actually called Top 10 Non-Dairy Sources of Calcium. There are lots of them. Then in terms of what also concerns me in dairy is that dairy is hormones. It's from pregnant cows. So you're getting the cow estrogen and the cow progesterone, but then you're also getting viruses and bacteria and other chemicals that may be in their feed, pesticides, other things. So I'm not a huge fan of eating a lot of dairy. Consumption of dairy is associated with increased breast cancer risk and increased prostate cancer risk and death from both of those. Now, that doesn't mean you have to cut it out 100%. What the research show is, eating more than I believe 2 or 3 servings per day is where the risk starts to kick in. And a lot of people are eating that and more. In terms of a vegan versus vegetarian diet versus omnivore diet, the research is also clear that vegans and vegetarians are at higher risk for osteoporosis than people who eat an omnivore diet. But the speculation by the researchers in the literature is that might be because the vegans and vegetarians are not getting enough protein. There are studies that showed vegans and vegetarians are not at increased risk. And the speculation is because they were getting adequate amounts of protein.
So let's maybe touch then on coffee and acidic beverages. And I don't necessarily want to talk about soda because we know that's not good for you, but there are healthier sodas these days that are made with stevia or monk fruit, or maybe even have probiotics, those kinds of things, but they still are more acidic. So is that something that's concerning from a bone health perspective? If we're bringing more acid into the system, are we potentially then losing calcium from the bones to buffer that acid, or is that not significant?
I think it's important to take any question like this in the context of somebody's overall dietary pattern, you know, and the quantity, how much somebody is consuming. Coffee is a good example of that. Coffee has great research now showing positive cognitive benefits, a reduction in all-cause mortality. But there's one study that came out years ago that looked at the amount of coffee somebody's consuming, and what it showed is if you're consuming more than, I think it was 5 cups a day, and not getting adequate amount of calcium in your diet, then the women in the study were at increased risk for osteoporosis. So it's not just one nutrient or having a soda every once in a while. I think it's really important to look at the overall dietary pattern.
In our listener community, hypermobility, Ehlers-Danlos syndrome, conditions like CCI or cranial cervical instability are becoming more common in recent years. We know that defects in collagen, which is a protein, play a role in those conditions. And wondering if you see any correlations between those collagen conditions, hypermobility, EDS, CCI, with less than optimal bone health.
I don't have that data in front of me to comment on that with any authority.
What role does glutamate play in bone health and its role on osteoblast, osteoclast? How should we manage glutamate levels to support bone health? And should we be concerned about maybe too much protein powders, or collagen, given that they all have L-glutamic acid, which can increase glutamate levels?
This to me goes back to the story of looking at a single variable in what is a very complex system. And I think that the glutamate, unless somebody has a real, pathologically high level of glutamate, in which case they're going to have many other symptoms going on, it's not really something that I consider or I'm worried about. What we do know is, again, it's about the overall dietary pattern. And it's not just protein, but it's protein plus getting enough plants, enough fiber, and those whole foods. That's really where those dietary patterns, to me, give the best indication of what is going to be healthy and what is not. And what we know is that the amount of protein somebody consumes can account for, just that alone, 2 to 4% of bone mineral density. But the researchers aren't parsing out, well, does it matter if it's a high glutamate, containing protein versus a low glutamate? First of all, that question has not been answered. Second of all, I just don't think it's as relevant as looking at somebody's overall diet and lifestyle.
We've generally been told to avoid nitrates in things like lunch meats and bacon. In the book, you suggest that nitrates may have a beneficial impact on nitric oxide, on circulation. Wondering if you can talk to us about the role of nitrates in supporting bone health, and then more broadly, how important is circulation and microcirculation for bone health?
Nitrates in food in processed food is very different than eating foods that increase nitric oxide production. So people are probably familiar with beets. That's a common one that people know, can help increase nitric oxide. That's a very different than eating a nitrate, which is a toxin in processed foods. When you get it from the whole foods and you're increasing nitric oxide, that is a vasodilator. It opens up the blood vessels and improves circulation. And this feeds into our conversation a bit earlier with blood viscosity and blood clotting. It's really important to have excellent circulation, because as your blood vessels get into those different tissues throughout the body, including bones, those branches of the arteries become smaller. The diameter through which the blood travels, which carries not just oxygen, but all your nutrients to those cells, is also smaller. So getting that optimal circulation is important.
How do oxalates play into the bone health conversation? Do oxalates directly impact or weaken the bones? Does a high oxalate diet lead to more demand for calcium in response to the oxalates, and that potentially weakens the bones over time? What's the connection between bone health and a high level of oxalate?
I don't know the answer to that question because, first of all, in terms of my recommendations of how I work with patients, it's not going to be a high oxalate diet anyway. It's probably actually not going to be a diet that's high in any one specific nutrient. It's going to be well balanced. Where oxalates become a real issue and a challenge are when you get kidney stones, and the majority of kidney stones are oxalate kidney stones. And then people are asking the question of, if I'm supplementing with calcium, is it going to increase my kidney stone formation? And what we know is that if somebody does have oxalate kidney stones, the calcium citrate in the citrate form is the form you want to take, because that does not increase the risk for oxalate kidney stones.
Yeah, and I think it actually helps if you have the calcium citrate and you have some dietary oxalates. I think that helps to minimize the effect as well. What if someone has a high anion gap, potentially metabolic or lactic acidosis? Is there then a potential for calcium to be pulled out of the bones to buffer that acidity? And how do we then want to think about addressing or mitigating acidosis to minimize bone loss?
The buffer for the blood of calcium does come from the bones. That is, as I mentioned before, the reservoir of calcium. So eating a more alkaline kind of diet, something that is not stressing the system as much in terms of acid-base balance. Now, if there's an underlying pathological reason why somebody has a large anion gap, then really investigating that further with a specialist, and trying to understand that becomes important. But in general, if somebody is eating 30 grams of fiber a day from whole foods, from plants, fruits and vegetables, and they're going to be eating a predominantly, alkaline diet.
What is the role of chronic infections in bone health? Many of our listeners have chronic Lyme disease, Borrelia, Babesia, Bartonella, chronic viruses, gut imbalances, SIBO, as you've mentioned. So what is the role of chronic infections? And then, because this is also kind of related to our listener base, what about mold exposure in our homes, workplaces, schools that are producing mycotoxins, and those mycotoxins potentially having a detrimental impact on bone health?
One of the challenges is that all of these, or I'd say one of the common themes among all of those examples you gave, is they all activate the immune system. And chronic immune activation, the increase in inflammatory chemicals, what are called inflammatory cytokines like interleukin 6, IL-6, those damage bone, those increase osteoporosis risk. And so any of those chronic inflammatory conditions are going to be a risk factor for bone loss and osteoporosis.
In our last several minutes together, I want to get into some of the potential therapeutic interventions. First, let's touch on the pharmaceutical interventions. You've mentioned bisphosphonates like Fosamax, Boniva, Actonel, Reclass. We also then have the parathyroid hormone analogs like Forteo. So what are the pros, if any? You've talked about the cons. Do these increase bone strength and quality? Do they prevent primary fractures? I know some dentists won't even place dental implants if people have used these medications. So is there a scenario where these pharmaceutical bone supporting medications are ever the best path forward?
Well, by the best path, I interpret that to mean the only path forward. And I don't believe that just doing one thing is ever indicated with osteoporosis. Now, whether a medication is appropriate is a decision for each person to make. They need to understand the potential benefits and the potential risks. In postmenopausal osteoporosis, what we know is that the medications will reduce vertebral fracture risk. If you've never had a fracture before with osteoporosis, that's what's called primary fracture prevention, but not reduce the risk for hip fracture except for one medication, which is Zometa. Zometa will both reduce vertebral and hip fractures in osteoporosis if you haven't had one before, a fracture before. If you've already had a fracture before and then are looking at the medications to prevent another fracture from happening, you have a lot more options. A lot of these other medications, or all the other medications, except for, I think it's Boniva, have been shown to reduce both vertebral and hip fractures. By how much? Well, a lot of that is a challenge because you've got to look at how many people are taking them in the real world versus in controlled clinical trials, and how many people actually take it long enough. In order to get the benefits from the medication, you've got to take the medication 70 to 80% of the time for 4 years. What we know with the bisphosphonate, oral bisphosphonates, is over half of the people stop within a year because of the side effects. And after 2 years, it's, I think, 70% or so are no longer taking the medication because of those side effects. So you've got to be able to commit if you're going to do that, and make sure that it is appropriate for your diagnosis. Because like I mentioned before, just because you have bone loss, a medication may not have been shown to reduce fractures in somebody with your diagnosis. If you have a proton pump inhibitor induced bone loss and somebody recommends a bisphosphonate for you, like Fosamax, well, that actually will increase your fracture risk. So just learning some questions to ask. And in my book, on my chapter on medications, I give questions for people to take to their doctor so they can just make sure they're getting the best information.
You say in the book that calcium and vitamin D can reduce the risk of fracture by as much as 23%. We've talked about the fact that ideally calcium would come from the diet. But if someone is supplementing, and we're going to talk about some of your products as well, do we need to take the calcium away from other things to maximize the absorption? And then there's a popular company out there that suggests that the form really matters, that deriving the calcium from algae or plant is better than maybe deriving from rock. And so I'm wondering what your thoughts are on the source of the calcium, and what is the source of the calcium in the products that you've created?
So there's no indication that one form of calcium, one source of calcium, is superior to any other source when it comes to reducing fractures. A lot of companies in their marketing will show you, if they've done studies on their products, that it improves bone density. But as I mentioned before, that only predicts 44% of women who will break a bone. The most important thing, and 21% of men, the most important thing is, has it been shown in clinical trials to reduce fractures, the nutrient or combination of nutrients? Currently, there is no indication that one form of calcium is better than another at reducing fractures. The form of calcium that I use in my bone support products is calcium citrate, because it is one of the more absorbable forms of calcium. And because even if somebody has low stomach acid, they will still be able to absorb it. So that's why, and if they have kidney stones, if they have the most common kidney stones, they'll still be able to take it. That's why I use the calcium citrate.
I want to talk a little more about D3 and K2. You've already talked about the ideal levels of D3. We often want to take, or maybe even always want to take, D3 with K2. You talked about in the book that K2 can reduce fractures by as much as 87%. You've talked about the MK4 form being the best for bones. You've also talked about the dosing in the Japanese studies of 45 milligrams, which if people look at their supplements, the vast majority of them are something like 180 micrograms. So those are not in the realm of what we're talking about.
Which is also, if I just might say, is the MK7 form of vitamin K2, not the MK4 form. So MK7 form has never been shown to actually clinically work.
So let's talk then about whether or not we need to be concerned about vitamin K toxicity, given that it is a fat-soluble vitamin if we're taking 45 milligrams on a regular basis.
With respect to vitamin K and vitamin D, in the synergy between those two, what the clinical trials show is, so first of all, when you look out there at the products out there that combine vitamin D3 with vitamin K2, every one on the market except for my Osteo MK4 product has the MK7 form of vitamin K2 in it, not the MK4 form. My Osteo MK4 product is the only one on the market that combines the D3 with the 45 milligrams of MK4 and no calcium. What the research shows is that MK4 alone can improve bone density at 45 milligrams per day in divided doses. But when you add the D3 to that, the benefits are even greater. You get even better bone density improvements. And then looking at the fracture outcomes, as you mentioned, the clinical trials looking at MK4, 45 milligrams per day, and fractures show in those volunteers over 70% reduction in fractures. And people have been taking that dose and even higher. There are clinical trials in patients with cancer taking MK4. It's the only form of vitamin K shown to have anti-cancer properties. And in fact, it's the only form of vitamin K produced in our own bodies. So all forms of vitamin K, K1, MK7, and MK7 is only produced by bacteria. All forms of vitamin K, when it enters our body, are transformed into MK4. And that's what accumulates primarily in tissues throughout the body, except for the liver, which is primarily vitamin K1. And researchers have given 45 up to 135 milligrams per day of MK4 safely. There have been clinical trials of people taking it for years. It's been MK4, 45 milligrams per day has been approved by the Ministry of Health in Japan since 1995 with no dangerous blood clotting effects in people with healthy blood clotting, no dangerous side effects. And the LD50, that is the lethal dose that kills 50% of the animals, that's what the tests and toxicology studies use, that in safety studies, that it's kilograms per day. You'd have to eat, a couple kilograms per day of this nutrient for it to have toxic dose.
One of the things in the book that I found interesting was that vitamin K can reduce NF-kappa beta. So talking about inflammation, even some of the matrix metalloproteinases, which in the Lyme and mold community, we're often talking about MMP9. One of the things that's commonly said about vitamin K is that it potentially could increase the risk of blood clots. It sounds like it does not have any significant effect on either blood thinning or blood clotting. So should we be afraid of vitamin K?
It does not have any effect on blood clotting if somebody already has healthy blood clotting. It's like the clotting cascade that we talked about earlier is the analogy I use. It's like a conveyor belt. Once you have enough vitamin K for the enzymes to be working at their maximum speed and creating some blood clots, you're not going to create it any faster. It can't go any faster once you have enough vitamin K. So giving even more of the MK4 that is used for blood clotting into your body, the MK4 just goes on and does other things in the body. So for example, MK4 specifically, and this is one of the challenges in the research, when you look at the research out there and they talk about vitamin K2, a lot of times they just say K2 and they don't define the form. When I go and actually reach out to the researchers, say which form did they use, they primarily are using the MK4 form in all of these examples that I'm giving today. And that is, for example, that it helps build, it's important for the myelin sheath, for the lining around nerves to form. The MK4 has been shown to modulate immune function and decrease, as you mentioned, the NF-kappa B. That was a liver study that was done with MK4. So making sure that it's not just the vitamin K2 as a category, but the right form of vitamin K2 in the right dose is important.
Boron is another mineral that's been discussed in the bone health arena, said to play an important role in osteogenesis, bone development, regeneration, as well as preventing calcium loss and bone demineralization. What are your thoughts on boron?
There are no clinical trials showing giving boron improves bone density or reduces fractures. Boron became kind of popular in the story about bone health because if someone is low in magnesium, they'll have increased boron excretion. And that was then an increased calcium excretion. And so, no, there are no clinical trials. I think it's popular in a multivitamin, and a lot of people should be taking a multivitamin and maybe get a little extra as a general supplement. But with respect to just a very targeted approach to bone health to improve bone density and maintain bone strength, there are only 4 nutrients that have been shown to both improve bone density and reduce fractures: calcium and vitamin D, MK4 in the dose of 45 milligrams per day, and another mineral that I imagine you will ask me about in our remaining time, which is strontium. And strontium, though I don't use it. There are no clinical trials on strontium citrate. All the clinical trials came out of Europe, out of medication that was taken off the market for a while, because what they discovered is that for every one fracture that was prevented, it also created a blood clot that can create heart attacks and strokes and pulmonary emboli, blood clots in the lungs. So for every one person that medication was helping in terms of reducing a fracture, it was also potentially killing them. The other thing is there just simply are no clinical trials on safety or efficacy of the form of strontium that's used in dietary supplements in the United States.
That was a great answer to my next question.
And it gives a false bone density test result. So even despite the limitations of the bone density test, I want the test to be accurate. And if you're taking strontium because it's a mineral that incorporates into bone and it's heavier than calcium, the bone density test results that you get are inaccurate. It's not an accurate test result.
Does exogenous collagen supplementation move the needle in the direction of healthier bones? I know some people are using collagen peptides. How much collagen should we consume on a daily basis? And then of the 16, I believe, types, is there one that matters most? If we're going to supplement, should we use a blend of different sources like bovine, marine, eggshell, etc.? What are your thoughts on exogenous collagen supplementation for bone health?
The research shows that taking hydrolyzed collagen peptides can improve bone density. There are no fracture outcome study, but it improves bone density and it lowers CTX. MK4 and vitamin D3 also lower CTX. And that, as we mentioned, is a marker for collagen breakdown in bone. So we want that to be coming down if it's elevated. The type of collagen that is in bone is type 1 collagen. And there, as you said, are multiple types of collagen. Collagen is a repeating strains of amino acids or peptides, which are a few amino acids stuck together. And that pattern repeats. And the only difference between the types of collagen is what that repeating pattern of amino acids looks like. But you're getting all the amino acids. It's not a complete protein, so there's typically one amino acid that may be missing. But I don't know that it necessarily matters which type of hydrolyzed collagen you're getting. Most of the clinical trials that showed improvement in bone density used types 1 and 3 hydrolyzed collagen, which is bovine collagen. And that's what showed to improve bone density. There are some proprietary collagen blends out there that were manufactured by a company that also has been shown to improve bone density in their clinical trials. But when you're looking at generic hydrolyzed bovine collagen types 1 and 3, which have been the ones shown to improve bone density, you're looking at 10 grams per day, which is typically one scoop for most products, including mine that I created, that has been shown to move the needle on the test and the bone density, on the CTX test and the bone density.
Melatonin has been said to suppress bone loss and promote new bone formation. One study showed significant increases in bone mineral density after a year. Wondering if you think that melatonin shifts in the direction of bone health and supports osteoblastic and osteoclastic activity in a bone supporting manner.
Absolutely, it does. Yes.
One of my personal favorite supplements is butyrate. It can be helpful in supporting gut health, can be anti-inflammatory, help with gut motility, metabolic health, brain health, immune health. What does butyrate do for bones? And do we need to supplement it given that many people's microbiome these days is not producing adequate short-chain fatty acids?
That's a great question. And I think that it's difficult for me to give a definitive answer. Whether to supplement or not depends on a lot of different factors. Butyrate does have positive effects on bone. Butyrate also becomes low or problematic when people have a dysbiosis. So I think in the context of trying to identify and correct a dysbiosis to improve their gut health and reduce the inflammation in the intestines, because your healthy gut bacteria will produce butyrate, there could be an argument made for supplementing with butyrate during that process to help things heal. And that's how I think of butyrate.
There are technologies today like biodensity and osteostrong that are devices that you go to a gym-like setting and they use osteogenic loading to stimulate bone health. Wondering if you can talk about those tools, whether or not they work clinically from your perspective, or what about vibrational plates that you can get at home, like the Power Plate or Life Pro or something along those lines?
None of those technologies have fracture outcomes data from what I know. And I looked a few years ago, I contacted OsteoStrong and I asked for their studies that I could read. And their technology does improve bone density, and that's great. Beyond that, though, what it does, which I think is phenomenal, as well as with the vibrational plate that can improve bone density, is it improves balance. And again, anything we can do to improve balance and reduce the risk of falling that's safe to do, I'm all for.
Is there a place for peptides like PTH-related peptides, bone-forming peptides, maybe BPC 157? Do peptides move the needle in the direction of bone health? And building on that, what about stem cells or exosomes for bone health?
First of all, collagen is peptides. So when you take an oral collagen, hydrolyzed collagen product, you are taking peptides that do get absorbed and have been shown to improve bone density. In terms of other peptides, they are, as I said before, peptides are, amino acids, small 2 to 3, 5 amino acids strung together. And bone is a highly protein dependent tissue, 180 to 200 different proteins in bone. Could peptides have some benefit? Yes. Bone morphogenic peptide is one that is commercially available as an oral supplement. And again, though, I would just say it's a very complicated system. Where do you draw the line in terms of how much money you spend and what you try to do? There's no fracture outcome data on bone morphogenic protein, which is just one of, again, about 200 different proteins. So boiling it down to just one, may or may not make the difference. For me, clinically, I like to draw the line where people spend the money on supplementation and therapies that have been shown to reduce fractures, and then spend their time on money on what they need to do to exercise and eat healthier, also things shown to reduce fractures. In terms of stem cells, that is an exciting area of research. I think that there's only animal studies that have been done to date on that, but I think that it is a potentially very exciting future area to keep an eye on.
You've created several products of your own through NBI Health that you could not previously get what you wanted at clinically relevant dosages. Talk to us about your Osteo-K, Osteo-K Minis, and Osteo MK4. What do these contain, and how does someone determine which one might be most appropriate?
They're very simple. They contain only 2 or 3 ingredients. The Osteo-K and Osteo-K Minis and Osteo MK4 all contain the clinical trial dose of MK4, 45 milligrams per day with 2,000 units of vitamin D3, which is enough vitamin D to get the vast majority of people into that healthy range that's associated with reduced hip fractures. And then the Osteo MK4 has no calcium. The Osteo-K Minis provides 400 milligrams of calcium per day who for people who need some calcium as a supplement. And the Osteo-K has 1,000 milligrams of calcium per day for somebody who needs even more calcium as a dietary supplement. The way to determine which one you need is, first, if your doctor has told you a certain amount of calcium to take or to avoid supplemental calcium, that can help guide your decision. If you are, you can calculate and track how much calcium you're getting approximately, that could give you a good idea. Because if you are getting 1,200 milligrams already, you don't need more calcium. And then, or you could just kind of estimate and say, I eat about the average diet in the US, the Osteo-K Minis to give me a little bit more calcium, 400 milligrams. Even if you're getting a bit more in your diet, taking 400 extra milligrams of calcium per day is still going to be in the safe range for you.
I understand that you guarantee your products, which is not common in the supplement industry. So talk to us about that.
Yeah, based on the research and having worked with this nutrient and product for over, almost 20 years now, we created the Strong Bones Guarantee. And we guarantee that anyone taking any of our bone support products that I created, that we guarantee that within 6 months, it'll stabilize or improve bone density. But more importantly, it will maintain strong bones. That means if you break a bone, we'll refund all your money for all qualified purchases between your 2 bone density tests.
Wow, that's pretty unheard of and incredible. My last question is the same for every guest, and that is, what are some of the key things that you do on a daily basis in support of your own health?
What I do every day is, first of all, I eat that Mediterranean style diet that I talk about. I exercise regularly. I look to get, my goal is an average is of about 7.5 hours of sleep a night. And really, I think a lot of what I try to do that sets the foundation for overall health fundamentally is work on my mindset. Is I take time every day to visualize in detail, what it is that I want, how I want to be, how I want to live. And that helps guide my decisions during the day.
Dr. Neustadt, this was such an incredible masterclass on bone health. I appreciate you spending time with us today and really breaking down this important topic. I absolutely loved our conversation. So thank you for all you do.
Thank you.
To learn more about today's guest, visit nbihealth.com. That's nbihealth.com. nbihealth.com. Thanks so much for listening to today's episode. If you're enjoying the podcast, please leave a positive rating or review, as doing so will help the show reach a broader audience. To support the show, visit betterhealthguy.com/donate. To get my newsletter, visit betterhealthguy.com/newsletters. To follow me on Facebook, Instagram, X, or TikTok, you can find me there as Better Health Guy. This and other episodes can be found on Apple Podcasts, Spotify, Amazon Music, YouTube, and Odyssey.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.